So I do have a presentation outline for you. I will show you the background on EPI and the health system that we have as a country. The health system, especially on the health information system that we have currently working on it, the issue of denominator on HPV, the challenge that we have, and the way forward, or the things that we are working to strengthen our health information systems as a country. So my presentation will have this outline, and I will focus accordingly. So to give you, okay, I will manage my time as well. The chair is warning me. So we have a population more than 112 million, and we do have 11 regional states, and we have around 115 zonal structure, more than 1,054 districts, so we call it warada. And where majority of our population also living in rural areas, which accounts around 83%. And Ethiopia also a very big country, and have a geography of 1.1 square kilometer square. So to give you some highlight on the health sector operating structures, we have a 3-tier systems to deliver our health service. We have a primary level service delivery. If you look at this one, we have health posts, health centers, and as well as primary hospitals, which are for providing the primary level care, and we have a secondary level, which is the general hospitals, and the specialized care will be provided by specialized hospitals and the university referral hospitals. In terms of coordinating all these structures, we followed the federal structure, and we have a Ministry of Health at the federal level, and the regional level we have regional health bureaus, zonal health department, waradas, and as well as Kabale level, we have an health extension worker. So the program is coordinated through this governance structure of the country. So it follows actually the structure of the country, how it is governed. So this is the facilities that we have. We have more than 395 hospitals. We have around 3,700 health centers. We have also more than 18,000 health posts where immunization program is provided. So in general, we have a facility that around 21,000 currently providing the routine immunization service, including the HPV. Actually, HPV is provided in a school modality, but it's also provided through health facilities as well. To give you some highlight on HPV, on EPI program, it was commenced in 1980 with 6 antigen, like most other African countries. Then later on, after 2 decades, where we started to introduce vaccines like PCV, Rota, IPV in 2015. HPV was also introduced in 2018. So later on, after that, we introduced MCV2. TT switch as well made in 2020, and the PCV switch also the same year in 2020. We switched from 10 serotype to 13 serotype. Well, COVID also came in 2021. To give you the framework of the health information system that we have as a country, we followed the principles like integration, simplification, standardization, participatory, and the continuity. So our health information system is guided by these principles, and it also encompasses the health building blocks like health financing. All the areas that we have as a building block will be will demand actually data and health information system. So this system will address all these building blocks of the health system. So at the end of the day, we need data information to improve the coverage of essential health service, health security, financial risk protection, healthy lifestyle and others will be an outcome of, the health information system as one building block. Later on, as an impact, we wanted to have an improved health status and economic gain as well. So in terms of data, we have a routine data system. We call it HMIS. ECHS, which is a community health information system. We have human resource information system. We have health commodity and the medical supply information system, LIS, RS, vital registry. All these are, the data sources for our programs. Again, we have periodic assessment like, service availability and the readiness assessment. We have a SPA. So all this information and the data will be utilized to improve our health system as well as programs. In terms of analysis, we focus on quality assurance, data quality assurance, triangulation of data, comparison of performances with target baseline with global standards. So different analytical modalities has been deployed, to show our program how it is progressing from time to time. In terms of communication, we have different platforms that we are currently using to communicate our data for global partners as well as for in-country stakeholders. So we have a joint steering committee. We have annual review meeting held by the ministry and the different directorate. We have different forums, midterm reviews, and evaluations, and the global reporting and the sharing of information has been followed through this modality. And we are guided by this health information system framework as in general in the country. So we are working and implementing this framework, using this framework to improve our health system information system. The other point that I can share for you is that we have a policy documents and the guidelines that was developed and established to improve, the health information system in the country. So it is guided by a policy and the policy document and the guidelines. So we have this documents, which is a live document. We are working on that. Similarly, the health information system structure also organized in a different level at the national, regional, zonal, as well as the district level, even including the health facility level. So we have the structures on health information system across all the levels, and including the community level information system. So we have ECHIS. We are currently starting to deploy it. Electronic community health information system also currently on board to have a robust information system. So we have a reporting modalities through DHIS2, especially routine information systems will be reported through DHIS2 as well. I need to be hurried because the chairperson also warning me there. Yeah. So let me focus on HPV actually. So in general, we are using a due emphasis to improve the health information system, improving data quality, decrease data burden, and improving the digitalization system is one of the focus areas that currently ministry is taking as an agenda and working on it to improve it from time to time. These are the core principles to reduce the data burdens, ensure data quality, and others. So these are the things as agenda we are working on it. So we do have different recording tools for HPV as well as other immunization programs. We have individual recording tools, registers, tally sheet, reporting format, DHIS2, which is a digital system. So these are the tools that we are using. So we have infant registry documents, tally sheets, and others has been used as you know it. So in terms of data elements that are reportable through our system, all immunization antigens have their own, that has been included in as a data element in our routine reporting system. So BCG, OPV, Penta, including HPV, were included in our data element, and the indicators has been also divided for them to be reported and monitored. So this is a copy of the previous data element. So we have this indicator similarly to be monitored across all the system from national to the lower level as well. So HPV is one of critical data indicator that has been monitored every time. Again, we have also logistics data like wastage rate, also one of the critical indicator monitored similarly to the other performance indicators. So in terms of reporting formats, all right, we have different reporting types. We have service reporting format, disease reporting, and FM reporting templates. Again, if you look at our reporting formats through institutions, health post will report, health centers, hospitals, and other clinics, private clinics also reporting. In terms of period, we do have immediate reporting and monthly as well as quarterly and annual reporting of administrative reports as well. Am I on time? Okay. I think it is a start. Sorry. So this is the reporting flow. So it starts from the community level, then it will goes to the facility, then it goes to the district, then to the region, and it goes to later on to the national. So the information flows will go from from the community and the facility to the district, then regional and zero, then to the ministry. So the reporting flow will follow this ladder. Okay. I think, yeah. Okay. I think it's not moving, yeah? So, yeah, in terms of denominator for HPV as a data, we are using a micro plan every year to capture 14 years adolescent girls. So we get this data basically from schools. So our service delivery modality is based in this campaign mode in a school platform every year. So every year we do have an exercise of micro plan for 14 years ago using the registers from the schools. Again, we will also use community registers, especially for areas that we have a low school enrollment, especially in the pastoral regions like Afar and the Somali regions, Benshangul, Gambela. So we used both. Majorly, we use it the school-based registries to have a micro plan. Again, for community, we use it community register, especially where school enrollment is low. Then we will validate this data using a central statistics data. So we cannot totally accept the data that we get from both from school as well as community register. Then we will try to triangulate and validate with the data that we have that is given by the Central Statistics Agency. So again, we will also look at the performance of the previous years. At least we want to be, fair enough to have the denominator for adolescent girls. So all this will be considered to identify our denominators for HPV vaccination. Still, there are a lot of challenges in terms of age trade-off, especially if you go to the rural areas, adolescent girls and mothers even didn't remember the actual date of birth. So a kind of 1 and 2 years trade-off has been happened. So we used this method to have a real denominator, at least, relatively valid denominator for HPV. Next. Okay. All right. So in terms of challenge, especially on our data system, to have a good denominator, our health information system still lacks a lot of limitations, and we have human resource limitation, inadequate functionality of the performance monitoring team at all levels, especially in the health facility and the district level. We have also documentation challenges, especially in an out-of-school vaccination program, and registration, especially for vital registration. Inadequate data quality also one of the challenge. Again, connectivity and infrastructure challenge also one of the rate limiting to improve our health information system, and a limited functionality of electronic medical record system also one of the challenge as a system it works for the whole information system, and again it works for also HPV as well. So to improve this as a way forward, the ministry is working on data triangulation as one strategy to mitigate the challenges that we have on denominators, on performances and other. We are also working on digitalization. A lot of investment has been going on currently to improve the digital system and to have a robust information system. Validation exercise has been going on, strengthening the performance monitoring team, also one of the strategy. Again, also improving the data culture use, also one of the critical things that the ministry is working as an agenda on it. Capacity building and increasing health information technicians or technologists as a profession, also the areas that the ministry is working to improve the data availability, data quality, and other things. So this is in general my presentation, and thank you very much, Mr. Chair. And if I am not on time, also I will apologize. Thank you.